Well, welcome everyone. We're excited to have you for our first Hot Topics event of the year. And Hot Topics is a new series that we're launching for 2022, where we pick one topic that is kind of the top of everybody's mind. And then we're going to kind of dig a little bit deep into it, or depending on the topic, maybe it's a brand new topic. And so we're going to stay on the surface, but we want to just have an opportunity to work on these hot topics throughout the year. Our first hot topic today is FHIR. We heard a lot of discussion during the fall about FHIR. And the question I got most commonly from our members is, what's that? So when there is something that, that people at ONC are talking about as if it's like, it's the language they speak every day, but it sounds something that none of us really know what they're talking about. We figure it's worth our time to help inform ourselves as to what is FHIR, and understanding how that impacts, or maybe doesn't, our lives as health data organizations and those who work in this space. So we're pleased to have with us some fabulous guest speaker. I think Joe is going to introduce them and moderate our panel today. But I'm just thrilled that so many people were willing to take an hour out of their Friday afternoon and join with us and learn about this fabulous hot topic. So Joe, go ahead.
Great, thanks. Thanks, Norm. And thank you very much to our panelists, Mike O'Neill, who is Technology Chair, Boston Health 2.0, and CEO at MedicaSoft, and Leanne Candura, who is the Director of the Population Health Team and Vice President at HSRI, which is the Human Services Research Institute. And if I'm not mistaken, I believe that's a slightly new title for Leanne, so we get to congratulate her on that as well. So I'm going to just really turn the floor over to our speakers. Each speaker is going to speak for a little while, then we'll have some time for questions and from the floor. You can use, I believe, I'm going to look at Charles, I believe that the chat function is enabled. So you should be able to provide your questions in the chat. I'm looking at Charles, is that right?
I think so, but
okay.
I admit it caught me off guard in the last meeting that it wasn't working. Yeah. So I'll send something and try and test it.
Yeah, so the chat feature again should be functional, and if it's not, the hand raise feature we know is functional. So you can certainly raise your hand and we can allow folks to ask their own questions. And if anybody is familiar with me as a moderator, you know that I use moderator discretion, so I will probably ask questions as well. So with that, I'm going to turn the floor over to Mike first, who's going to give us an overview of FHIR and start talking with us a little bit about some of the applications. So Mike, please.
Well, very good. Thanks. I'm glad to be here to share a few words on FHIR. Charles, actually, as we get started here, this somehow is not allowing me to share my slides.
The most recent message I got from them was thank you for that. I sent him my details.
I think we got some folks who aren't.
And then he said that he'll get his triage.
So if you happen to have my slides there and can share them, that would be great. And so as Charles brings those up, what I wanted to do is, as Norm said, sometimes the question on FHIR first is, look, what is it, or a little bit more pointed, sometimes it's what is it good for? Like, why do I care? So we thought we'd just take the first 10 minutes or so here and talk a little bit about that. So thanks, Charles, for sharing the slides. We can jump right into the next slide. If we start off and just think, instead of diving into the FHIR specification, which is sometimes what you do when you take a FHIR introduction, I thought we'd do the opposite, take a step back to why would we even need to think about something like FHIR? Big picture, healthcare systems that we were used to in the past and are kind of evolving away, often, you as a patient are working with maybe one doctor or one hospital. That doctor or that hospital probably has electronic system and has data. It's kind of in their domain, in their silo, if you will. If you go to another doctor, sharing those records becomes a thing. And yes, if you're looking at the slide, that's a fax machine there. That's, all too often the means of sharing health records. If we move into the whole payer side of the equation, there's another set of data in another database, and sometimes there's faxing back and forth for all kinds of different purposes. If we can, I know this fax machine syndrome still exists today, but we could view it as that's where we've been. Where are we going? Well, hopefully a system where we as patients we're more involved in our care. So we're involved with more than one healthcare provider and under sometimes our own control. We're more engaged there. Those healthcare providers, those provider systems are hopefully able to better share electronically your health records, whether that's through a state or regional agency. They may be sending data to or getting data from state registries, immunization registries, and vaccination registries today are a big thing, but there's a lot of different places where healthcare data can live. And in order to get to that, bottom rectangle that I show there on the slide, where patients, our providers, the systems that are paying for care are all able to work together to hopefully improve the outcomes that we get from care and the efficiency that we achieve in doing so. We really need to get to a position where we can all interchangeably access data. So in that kind of a picture, oops, I went to advance my own slides and forgot, Charles, if you could jump to the next slide. So in a healthcare system where we're evolving to that picture where it's more integrated, more people are involved and able to be more efficient in how they interact, what does that mean for those of us who work with healthcare data? Any scenario that you want to choose out of that very high level icon slide, the trend is towards more data and more kinds of data and being able to put it all into one place or share it. If we were going to do something like that and do it in a way that we can all live with, there are a few things we could really use. One is just a better way to represent the data itself. What I call a claim or what I call my health record may be different than what you call it or your systems. How do we get some commonality there? So a consistent way, and hopefully a simple way, to represent not just the clinical data, your health record, but any of the administrative data, the financial data that goes along with it. That would be great to be able to have some simple way, consistent way to handle this. And it would be nice if, for let's say the 80% of data that it's consistent or common to all of us, that there was no question on how to handle that. And then for anybody's unique case, there was an easy way to fit that in without breaking the whole system. If we have a better way to represent healthcare data, then very next thing we probably want is we could use a better way to transfer it or exchange it. If I need to send it to you to get something done, if it becomes a real IT nightmare, whether we're faxing or having to set up special connections, that's a challenge. That's going to be an impediment to sharing. Even for some of the electronic systems that we're already used to using, whether it's EDI, or for those of you who are familiar with something like HL7 messaging or sending CCDA documents, those help. But again, they tend to be in transferring, let's say, a large amount of data when all I care about is the visit that you had to the doctor yesterday. How do I get that? And it can be difficult to have a few simple methods to exchange data that work across all these systems. So better way to represent data, better way to transfer it. Those two things would be great. And that last thing that I'm mentioning here is just for the IT folks among us. It would be great if whatever we did with healthcare data just fit a little bit better with the way we all want to build applications today. For one thing, whenever we talk about healthcare data, there's a very valuable part of our industry that thinks a lot in terms of the theoretical nature of it. How do we encode healthcare data and those kind of things? That's important. But anybody who's been involved in healthcare data and modeling over the years, the industry went almost too far that way. It became so theoretical that it was very hard to build a real system. So it would be great if we had a model, a theoretical model, that was also easy to implement, easy to build. And it would also be great if it was very much in line with the way we all build cloud-based applications today and kind of modern web-based. So those are the kind of things that we would all wish for handling healthcare data. And Charles, if we could jump to the next slide. So FHIR was actually designed with many of those
Yes,
principles
I'm on
that
this call.
Oops, sorry, somebody's not on mute. When the HL7 organization first started to sketch out FHIR, some of the things that I just mentioned were really the drivers behind that. And so we have ended up now with FHIR being a system that gives us a couple of things, two main things. One is a very powerful data model, that simple, consistent way to represent all kinds of healthcare data, not only clinical data, but administrative, financial, be flexible enough to handle things like social determinants of health when we mention data types like this. FHIR is a data model that's easy to understand, easy to put your favorite data into resources is the term that's used, that others can understand easily. It very much adhered to the 80-20 principle, so that 80% of things that we all know we want to do, it's common. For the 20% where what I want to do is slightly different than what you want to do, there's a way for each of us to specify that doesn't break the whole system. Extensions to FHIR is something that's pretty easy to do. So from a data model point of view, FHIR gives us a great way to represent the kinds of data that we're dealing with every day. In terms of exchanging data built into the standard, which is a little bit different than standards like HL7 messaging, for example, an API is actually built in as part of the FHIR standard, an application programming interface. So for some of you, you're very familiar with APIs, and if you're not, the way that, in almost every industry today that web and mobile applications are built, use APIs. REST is the actual protocol as a way to build very efficient systems. So FHIR built the API right into the standard. When you implement FHIR, you implement a RESTful API. That gives you a way to not just easily represent healthcare data, but have confidence that your system will be able to talk to my system, which will be able to talk to the next system in very standard ways that most developers understand inherently. And that's actually a key part of that, the last point that I put down here. FHIR actually had as one of its objectives to create a standard that was explicitly developer friendly, that out of the box, you could build something using technologies that developers are very familiar with, represent data as JSON or XML. These are standards that are prevalent across the web. Even things like how we handle security and using familiar internet protocols, HTTP, using standards like OAuth, that's the authentication method for probably most of the applications that you all use today. It brings healthcare data into that very familiar internet application development world. So Charles, if we could go one more slide. So, I thought what I should do here to just keep this to about 10 minutes is it's great to say, okay, healthcare systems are evolving in ways that make it more important that we can easily use data. So we needed some standard way for us to all handle data. FHIR comes along and it does that. It's still to get to the second part of what I mentioned at the beginning. So why do I care, or what would I use it for? Well, one of the first things that for some of us that we may use it for is because we're told we have to, for things like the CMS interoperability rule. In the clinical world, there's ONC rule that says, look, if you're holding healthcare data, you have to make it available to patients, and you have to do it via FHIR API. There's good reason for that, and it's largely related to the fact that most of the applications that patients or regular people would use are going to look to connect to systems via API like FHIR. But setting that aside for a second, what does that mean to me if I'm running a claims system and I'm told I need to implement a FHIR API? Well, one of the things you might do right away is add it alongside your existing system. If you do the work to take the way you represent data today, your database schema or something like that, map that to the way FHIR represents data in relatively straightforward terms. You can now make your data available to the world via FHIR API. So this is a very common first step that you might take. Don't have to change anything in your existing system, kind of map data to this new thing, new FHIR standard, and then let people access it that way if they have a need to do so. I would suggest that we might think about what's on the next slide. If Charles can advance there, which is adding, actually on that previous slide, it's sometimes referred to as a FHIR server. Just adding a FHIR server next to your existing system can meet today's need. But if you think about longer term, you probably will have multiple reasons for people to access your data. Patients may have apps that they need to access data. Healthcare providers may be looking to exchange data with you, the payer community accessing data and so forth. You also probably want to get your data together in one place to do reporting, to do analytics. And if you think about the first slide that I showed there, one of the problems with the older system is that you end up with different pieces of data in different silos depending on what you're trying to do. It would be a shame if introducing a new standard like FHIR made that problem worse. You'd like to make it better. So one thought is FHIR as a data model is actually pretty effective. Maybe you can start to migrate some of your existing systems, some of your existing data to FHIR, put it in that repository, and then use it as a way that your applications can access it, your analytics access it, and it's the same way that you use it to exchange with others when you need to. I'm going to actually jump to my last slide here. There's clearly a lot more you could say, in this world, but I think that in just a moment here, Leanne is going to say a few things there. So let me just wrap up here and then pass the baton. So going forward, I think there's a few things that we see in the industry for FHIR. One is there is a push from the government. Both ONC and CMS have introduced regulations that kind of push us all towards the use of not just APIs, but specifically FHIR APIs. So that's something that tends to get things moving. And it's certainly my view, and I know I'm not the only one who has this view, that there is a way you could meet those regulations and just kind of check the box, let's say, stand up a FHIR API. That could be a little bit short-sighted. It may be the better thing is to look at your architecture over time and look at if FHIR is a good method of representing and exchanging data, then maybe it's something you can work into your overall platform and really take advantage of it as part of your longer-term enterprise roadmap. So with that, I'll wrap it up here and turn the baton over to Leanne.
Yeah, Leanne, take it from here.
Great. Let me see if I can share my slides. See if that works for me. Okay. It appears that it's going to work. Does everyone see?
Yes, it's good to go.
Great. So thank you. And thanks to NAHDO, Norm, Charles, Joe, and my fellow presenter, Mike. I'm excited to be here presenting on some lessons learned and future directions for health data organizations to consider when they start to understand FHIR and what all the opportunities are. If you would have asked me a year ago today that this is what I would be presenting on, I wouldn't have known what you were talking about. FHIR is new. It is new to myself and my team and my organization, and we were so excited to have an opportunity working with Maine and MHDO this year to get our hands wet with FHIR and really starting to understand and think through what are the future opportunities for health data organizations? What did we learn? What can we share, and where are we going? It was really helpful for Mike to present some of the more technical background on FHIR, and I'd really like to walk through, as part of my presentation today, sort of the practical implications for how we became involved, what we used it for, and where we see it that it's going. So quickly, I'm just going to talk a minute about, how did HSRI become involved in this, which kind of frames kind of our view and where we see it's going. Why FHIR? I think Mike already gave us some background on why we should be looking at it, considering it. And then what are the opportunities? So Human Services Research Institute has been my home for the past 15 years. As a not-for-profit organization, our history is built on systems change and improving systems that improve lives. And when I started our newest focus area at HSRI 10 years ago, our population health team, the real reason we were doing this work was to make high-quality data available to improve health policy and practice. And we started our work with the main health data organization to support their vision of a robust and secure data warehouse. Defining high quality data throughout the data lifecycle and engaging and understanding data users' needs to improve that data, and really, the focus on data standards and how those could be used to promote higher quality data and interoperability. So, that brings us to, why FHIR? There's no single standard that covers all possible healthcare applications, stakeholders. We use a variety of standards and corresponding implementation guides to define our processes for data capture and exchange. And those of you who've been active in NAHDO and the APCD world, all the work that's gone into the common data layout, for example, and the number of different standards that are referenced. So this just shows us there's significant opportunity to achieve greater efficiency and reduce the burden and cost for all parties through greater standardization and data definitions. And that gets me excited. So that brings us to talking about FHIR and what we've really learned over our short time getting to know and understand the FHIR standard, which the core goal was to create the standard that would lead to high adoption across developer communities. So I'm not a developer, but what I do and what I look to is how we can use technology to help support states in their health data use cases, and really the focus is on how can we get this information quicker, of higher quality, and how do we start to really begin to link and understand the full spectrum of care that's being delivered and the quality of that care. And so, it's really focused on having a standard data format that's open source, that uses modern technology, security really just built in to that standard, and that facilitates the interoperability and integration of systems. And so the systems themselves can, remain in their various silos, but having the opportunity for then this FHIR standard to be able to help them communicate because they're all using it. So that brings us to, right now, why should health data organizations really start paying attention? And I know Mike touched on this, and many of you have heard or been involved in the interoperability rules. But CMS has really put a hard focus and requirements that payers adopt these FHIR APIs, and there's a requirement that all Medicare Advantage organizations, state Medicaid agencies, and qualified health plans in the federal workplace or marketplace adopt these standards. And I know that there was, a deadline, and COVID, still ongoing, but I think there was some relaxation of the requirements around adoption last year. But many states and Medicare agencies really had to, dive in and understand what the requirements are related to these new interoperability rules. And so this really created an opportunity for our work with the Maine Health Data Organization, where we were already working to support a provider directory. So the interoperability requirements has a couple of the key areas were a patient API and a provider API. And the Maine Medicaid agency, MaineCare, we were already in conversations, MHDO was already in conversations around this provider directory, which is such a key piece to understanding and used across the different healthcare data sets that we were working with MHDO to be responsible for, putting a hierarchical structure in place for hospitals and healthcare systems, their providers, and the practices within their systems to have a common directory or database for everyone in the state to be able to use. And so that's really where our involvement with helping MaineCare meet their API requirements, because we were already getting their provider data of who was in their provider system. And those of you who aren't really involved in understanding why state Medicare agencies were being required to do this is they wanted the information available on an API through their website so other developers could use that information to ensure that everybody had access to up-to-date patient and provider information in this standard format. And so we helped the state meet those requirements using a FHIR implementation with the data that MHDO was already receiving. And so we were helping within the state make the connections with this information, and then also using that to drive other work that we were already working with the state on. I presented briefly on some of this work at this past year's NAHDO conference, and so this graphic has been used in that presentation as well. So we were not only working to support this directory, which had this hierarchical structure, and supporting other work that MHDO was doing with other state agencies. And so it was just a really natural offset to be doing this provider API work as well, using the information we were already responsible for. And so now I just want to talk a little more specifically about the use cases for the provider API. So what you would be able to do using, so the requirement was that you post, that the state Medicaid agency posts the information on how to access the API, and then a developer or other entity then make calls to that API to get up-to-date information around practitioners within the state, including by different region. You can search by organizations, by name, by address, or different relationships. So examples, practitioners within a specific health organization. And really what this was trying to, solve for is to make sure this information was available, that this, somebody was, that this represents the Maine Medicaid provider network. And if somebody was trying to build a tool to help patients find entities within the network, that they could use this API that has, requirements of how often it has to be updated built into it. So within, 30 days of an update to their provider network, it's required that it's made available. So it's really trying to ensure that everyone has access to this information about different care structures. And so this is a fun image. So what this represents, and of course this is, there's so much documentation. This might be a good follow-up for any of today's attendees, just the amount of resources available out there in understanding all these different modules available within the FHIR framework. And what this represents is the affiliations and roles within the provider portion of the standard. And so it really provides a flexible framework to tie different practitioners to different organizations. And I will say that when we were originally working on this hierarchical structure with Maine, prior to being engaged in the FHIR work, we wish we would have been familiar with the structure that they were setting up in here. Now, granted, what we did develop mapped very easily into this, but it does provide some of these structures for health data organizations to understand, how is this being done through HL7. So this is the representation of how the provider database is structured within FHIR. And this is a bit of a simplified version. All the different roles, I think the great thing that's also built into the standard is that, while the one that we did for Maine Medicaid, which is Maine Care, is that it's just for the Maine Care providers, but we could easily load in other insurer networks and then make that available as well. And so this is also just a representation of some of the definitions or how the definitions are set up and requirements within the standard. And of course, this is all publicly available and open source. So that is some exciting work that we started or implemented last year with the MHDO, and we are now in our maintenance phase, so getting all of the updates in. Again, it's, we had done the mapping exercise of the provider information and the files that come in from Maine Care, and now that will continue to be updated and available to developers. One of the things that we wished we had when we were working on this is that there was more information about what other states were doing and how other states had implemented it. That wasn't available. We haven't, I'm sure, and maybe there's some on today's call who can talk about how their state has implemented their required APIs and what tools that they used. We did use MedicaSoft has a FHIR server that we did deploy for this application. There's a number of other, I think AWS, there's other, public entities who are having FHIR servers available to use. And I think it is such a novel use right now, and really there are a lot of states are just beginning to implement this, that there wasn't a lot of information available as we were working through. So opportunities. So as I mentioned, a lot of the work that we've done is within APCDs and hospital encounter data systems, where there's different silos of information within different systems. And so this is a framework. This is from the HL7 website, for which the FHIR standard was built off of, and this provides the foundation and with the supporting implementation documentation, and then the different modules. And so what you begin to see is the way that this has been, where FHIR especially stands out is the ability to support, vital use cases that benefit providers, payers, and, health data organizations. It'll facilitate information sharing. And so, as an APCD, we just, maybe receive information from one of the buckets, and the opportunities really are in the future that because all of the record keeping information would be stored in similar ways, that there's a lot of opportunities for the combining of that information, regardless of what system it comes from. And so just really quickly, this is really reiterating some of the things I've really touched on, that we really see a lot of opportunities in the future for, the integration because of the flexible framework. And it can be used to map into other structured frameworks like the CDL, but it does provide some additional flexibility. It easily supports linkages and interoperability. So I think Mike may have had a slide, you have all these various data systems, and if that we start using the same standards with the common languages, those linkages will be able to happen more easily. And so that gets at the reduced burden piece. And it's a common resource, really, once you start diving into the website and materials, it's pretty intense. So there's a lot of information out there and a lot of communities that's come together around this standard in the healthcare world. And so that's what I really want to say, that the perspective of a health data organization, as a state health data organization, as a vendor who works with state health data organizations, we really need to start thinking about how we can be at the table as the future development of this takes shape, and to ensure that we understand and know the direction that, for example, CMS is going, whereas they may be, obviously this is really the language that they're speaking now, and are they going to implement some requirements that really impacts APCDs or other healthcare data sets? Because they're making some requirements related to FHIR standards, we need to be ready for the future impact that it could have on us. So that really gets me to 3 takeaways. Last slide. That, because CMS has endorsed this as their preferred healthcare interface mechanism, it's here, right? And so we need to understand what that means and how we can start adopting it. As I've said a few times, it's a standard, not an implementation. It is designed to solve, real world problems. But it also does not provide the guidebook to how you are going to implement it within existing systems, future systems. So that's really where I think conversations amongst similar groups around thinking about how we would want to implement it is going to be really helpful. And finally, that it facilitates system-wide communication so that can really improve identifiers. I know we've been in lots of conversations recently about, as I said, providers or individuals, and making sure they're being identified the same way across the health data ecosystem. So that's it for me. I know we're going to have some discussion items, but thanks for inviting me. And again, I'm excited to talk about this topic.
Thank you, Leanne. And thanks, Mike, also for your comments. I'm not sure if Charles is on audibly or not. I'm not seeing a chat. I don't know if other folks are. So we may be reliant on you in the audience giving us a virtual hand raising. So if you don't know how to do that, there's a little icon with a emoji and a hand raising up in hopefully the upper right hand corner of the Teams page. And if you click on that, you should be able to raise your hand. So we welcome you to do that. I think while we're waiting for folks to join in to the conversation, I'll ask a question or two. One is, you both talked extensively in your remarks about the future applications of FHIR, and Leanne, I think you did a really good job of talking about some of the needs to be part of that future development. Could you, maybe Mike, we can start with you. What's from your perspective and what you're seeing and what you're hearing, what's currently, in a sense, kind of funny, what's currently future development? So what's complete, what's more to come? and referring back to Leanne's comment about what, how to be at that table, what's on the development cycle that you're aware of? So there's, maybe some stuff that we should be directive around from being at that table.
Sure. So yeah, so there's a few things, so first, FHIR, it's not done, it's not static as a standard. So that, I think that's important to note, which means it's an opportunity, right, to weigh in on where it should go. So some of the things that I know, or we all know, are being worked on are, it's one thing to say patients should access data via FHIR API, but how do we protect security? How do we protect privacy? There's work going on to make it easier to connect securely and protect privacy. So that's some important work. There's work going on to, in fact, Leanne, you may have mentioned bulk transfer. There's work to go on to say, hey, what are some of the use cases? And this is an area where any of us here would be able to weigh in with. If the use case is, I need to transfer someone's entire record from one payer to another, it's hard to do that by please give me your vitals, please give me your problems, please give me your medications. You just want to do that all at once. Great, there's some work going on for things like that. There are also use case specific groups that are working now through the HL7 organization, and some of you may know names like Da Vinci or Argonaut. Those get created when a group of people say, okay, I understand the specification, here's how I want to use it. I'm maybe a relevant one, the payer community, I'm going to want to and need to get more clinical data from the provider community. How can we do that efficiently? And then a work group gets formed there. So I would encourage folks, if you have some of these use cases in mind in the short or medium term, look at what those groups are doing and get involved there. There's plenty more that I could say. I feel like I want to make sure that Leanne might have some things she would weigh in on here too.
Yeah, Leanne, please.
Yeah, and Mike, just echoing what you've said, unless our use cases are at the table, it will be much longer until they can be addressed. This is all very new. We found a lot of interesting things as we really dove into trying to use the standard for the provider API. And I will say there is a reason we agreed to do the provider and not the patient. I mean, certainly the security implications from the patient data perspective versus the more public provider perspective give us a little more comfort in us understanding how to use and render these providers. And so wanting to figure out how the best way to engage in both some of the details around, okay, if you're looking at a standard taxonomy, here's the taxonomy standard that we think should go in this box. Like that, literally, the conversations we were having while doing the provider. And I want to make sure that, if the state of Maine decided to put this provider taxonomy in this box, that other states who are also implementing made similar decisions. And I don't know a venue yet. Like, I would be interested. I don't know if others on this call are familiar or were engaged with their states who also may have been implementing meeting these interoperability requirements. But making sure that when you do make those decisions, that you're putting that information out to these working groups, because it is new. It's not written in stone. They are going through all of these, changes, and we can either be part of it or we can have it happen and then have to figure out afterwards what we're going to have to do about it. But I think there's the opportunity.
That's great. That's great. I'm scrolling through our attendees looking for virtual raised hands, or anybody who's coming off camera and unmuting, which is the sort of virtual meeting universal sign for I want to say something, is when somebody's microphone goes off mute. And I'm not seeing any right away. So let me ask a little bit about, Sunil. Sunil, I'm sorry if I said that wrong. Oh, there was briefly a raised hand that retracted. Oh. Sanella, interested in a comment, question? Okay. So I think, one of the questions we'd have for both of you is, from your perspectives, and maybe Leanne, you probably, you touched upon these, but maybe reinforce them just a little bit. Some of the challenges that might, I'm not sure if resistance is the right word, but might cause some pause in moving towards this as a standard. I understand the pressures to do so, but what are some of the pause points that maybe you're hearing in the community as folks are sort of required to move towards this? Maybe Mike, you could start, and then Leanne, you could jump in.
Pause points that I know that we've encountered is sometimes there is, if it could be led by the technical part of the organization, hey, we need to do this, and the pause or pushback, you might say, is from the business or clinical point of view, like, why now? I have other priorities. What is this good for? So I think this is not actually unique to FHIR or even unique to healthcare, but it's a good idea to think about, the why in any investment, right? And that would apply to FHIR as well. So what am I trying to do here? Is this because I need to enable patient engagement? Or is this because I'm going to start working with another organization and we needed to agree on a way to exchange data and FHIR? Whatever that reason is, that should absolutely guide what you're doing from a technology point of view. And to come back to what you asked, when do we see pushback? Sometimes when you let one of those pillars drive without involving the other pillars in why you're trying to do what you're doing.
Thanks. Leanne, do you want to offer anything around that? And then we'll go to a question in the audience.
Well, as I mentioned, the impetus for us, working on this project was the fact that there's a federal requirement that had some money attached to it, right? And so this was being funded, and I guess the biggest pushback was around how do we prioritize this? We know there's these deadlines, at least there's some funding, but nobody is quite clear on who's going to be using it. Like, it was hard in the testing because we go through testing phase. Like, how many hits are going to come off of us making this available? And nobody really knows or could say, and there wasn't really much out there with the expectations yet about how to test for that. What are we promoting? Did we put the right resource out? Because it's going to be getting one hit a month, 1,000 hits a day. And I think part of it is just because it's been a really slow rollout that maybe we just won't know that for a while. But who's looking to find these resources from, in this example, the main Medicaid perspective, and how should or could it be marketed for use? I think it's just really an open question.
Okay, great. Excuse me. Richard Gibson, I see that you have turned on your mic and joined us on video. Please feel free to ask your question. If you don't mind letting us know where you're coming from, that would be great too.
Hi, I'm Richard Gibson at Comagine Health in Portland, Oregon. And we will be using the HSRI database later on this year. So pleased to see your presentation, Michael and Leanne. A couple of questions for you. Number one is, do health data organizations feel that they need to respond to the 21st Century Cures Act, either through ONC or through the requirements of CMS? Because without being a payer and without being an HIE and without being a provider, I'm not sure that health data organizations need to use FHIR to meet the 21st Century Cures Act. That said, Leanne, your examples of the provider directory are superb, because that's a fabulous example of how to use FHIR, is all the things that can be done with the provider directory, but not all the health data organizations provide a provider directory outside of their internal use for data. So that's the first question is, do you feel a need to use FHIR? Not just that it's out there, but do you feel a need to use it? The second thing is, do you see any data exchange that's going on now between payers and providers and health data organizations being replaced with FHIR? So a current exchange that's not FHIR being switched over to FHIR. Thank you.
Maybe I can say quickly.
Yeah, that'd be great.
You're in a probably better position, but what we have seen, and I should say first, we are not a health data organization. We're actually a software company that ends up being a technology partner to an HIE, a payer, a health data organization. So sometimes when it does, the ONC or CMS rules don't directly apply to them, what they are doing is saying to some of their stakeholders, hey, I'm in a good position to offer this as a service for you because I do these things. And so if I make this investment and let's say provide the infrastructure for provider directory, I do that once, you can leverage it. So if that's helpful at all, we've seen several cases like that. And I would say both on the ONC clinical side, where an HIE has done this and then told providers, if I offer the service, the collection of you can use it, and the same thing for the HDO payer side. Leanne, does that sound reasonable from your point of view?
Yeah, absolutely. I mean, I don't see a current, as working with health data organizations, unless again the feds decide that they're gonna invest, which would be great, in us really trying to solve this issue. I will say the questions that I get asked, or the use cases or the problems that we're trying to solve, every day working with health data organizations, are about interoperability, wanting to create more linked data sets, wanting to be able to identify individuals. And I see this really supporting solving this in the future, and that it should be something that we're always kind of referring back to. Okay, what is it in the FHIR standard? How have they done it there? If we're looking at our data structures and our data models today to solve this, and it could just be within a state, two agencies trying to share information, is there something in that standard that's already kind of looked at this and solved it? That we should start referencing that and making use of that, because I think that is how it's going to get us to ensuring that we're going to be there and ready once there may potentially be more requirements.
Great. Well, I know we're bumping right up against time. That's usually my signal when Norm comes back on camera, is that I need to wrap up the session. So I'm going to take my visual cue and do that. I would like to thank Mike and Leanne for taking the time to present and talk with us today. I think there's probably no better way to start off a new year than to think about something that's forward looking and future planning. So really appreciate you both taking the time to join us for the NAHDO's first hot topic of the year. Norm, I'm going to turn it right back over to you.
Thank you, Joe, and thank you also, Leanne and Mike. This has been a fabulous discussion, and we're glad to see so many people engaged and be interested. Our next hot topic, we're going to focus on standardization and harmonization. And if you have any suggestions for what you'd like to hear underneath those headings of standardization and harmonization, please drop us a note, and we will try to include that in our materials and presentation. So we'll see you in March, and hopefully everything is good for everybody to have a happy winter.